Hello, everybody. This is our one and only cervical post-operative presentation. And I say one and only, there's actually two parts. So with this first part, because it's really our only cervical post-operative presentation, I would like to spend a little bit more time reviewing clinical practice guidelines and talking about the non-operative treatment for these patients. And then the second half will actually be the operation. So what does that look like? And then the rehab. So this really today is mostly just about the cervical spine. And I think it's important that we do that because we don't really have the opportunity to do that again throughout this series. So let's start with anatomy. We generally consider the upper cervical spine being the occiput to C1 and C1 to C2. And then the lower cervical spine is C3 to C7. And you can see from the picture here, we have lots of nerves that travel around that area, and then the nerve roots that are coming out of either side that travel down the arms. And that's really what we're focused on as we talk about these patients deciding whether or not to have surgery and then post-operatively. So here's just another picture reminding you of the anatomy. So again, if those of you who don't know a whole lot about the anatomy, C1 and C2 are very different than the rest of the cervical vertebrae. When we talk about cervical fusions or any surgery related to the cervical spine, it's most likely that it's happening to the lower cervical spine, so anywhere from C3 to C7 and T1. Fusions tend to happen more in China than they do in the United States. And we tend to have larger fusions where the fusion's happening at multiple levels of the spine. And so it's important that you sort of recognize the anatomy and understand how many levels have been fused, because that obviously is going to affect their range of motion, their ability to move. Another picture here, recognizing sort of the facet joints of the cervical spine, different vertebrae, and then C7 having a very large spinous process. So you'll see again in this picture C1 and C2 very different than the lower vertebrae. And the facet joint orientation is what allows us to move into rotation. It kind of limits our side bending a little bit and allows for flexion and less extension. And again, because C1 and C2 are different, C1 moves on the occiput to allow for a certain amount of flexion, probably about 50% of our flexion and extension. And C1 moves on C2 to allow about 50% of our rotation. And so if you're fusing below those levels, which again is usually what you're going to see, then you're still going to be able to get at least 50% range of motion, even if the entire lower cervical spine is fused. So again, just another picture, you can see specific cervical vertebrae here. The body of the vertebrae looks very different than the lumbar spine. It's much smaller, but we have a much larger vertebral foramen, which is the hole there in the middle. And that's because we have a large amount of our spinal cord that travels through this area. And as we move down the body, then we lose bits of the spinal cord because we're losing that to nerve roots that are actually traveling to other parts of the body. So as we get down to the lumbar spine, that foramen is smaller because our spinal cord is smaller, and we actually have a larger body of the vertebrae because we need more stability. And so it's important to recognize that spinal cord is large in this area and that hole is large, because that's going to obviously, if there's issues with that, and we have narrowing of around the spinal cord, then we're much more likely to have issues all the way down below the cervical vertebrae, all the way down through other areas of the body, even down to the legs. So that's important to recognize, because a lot of the times we end up having surgery done. These patients are having this surgery done because that foramen has narrowed, and so they're starting to demonstrate symptoms in their lower body and in areas where there might be some central cord symptoms that are specific to problems of the cervical vertebrae and the spinal cord traveling through this area. We also have to think about the small holes with what's called the transverse foramen, which you can see here as well, those little holes on either side of the body of the vertebrae. That's where we have the vertebral artery traveling through. And so if that becomes narrowed, then obviously we have issues with that artery. And we only have 2 major arteries that go up to the head. This is the one of 2. And so if there are issues, then it can lead to problems with circulation to the head, which we all know can be a problem. Also unique to the cervical vertebrae are what are called uncovertebral joints and the uncinate process. And so you'll see here that the vertebrae themselves at the body actually kind of makes a U. And that is really to help decrease or kind of limit the amount of side bending that we do so that we don't over side bend and cause pressure to our nerve roots. So our nerve roots are traveling through the uncovertebral joint area. It's important that you really recognize this anatomy, because what happens is as we get older, sometimes this area between the 2 vertebrae, the uncovertebral joint, actually ends up narrowing. And when that happens, then we have more issues with the nerve roots. And this is a main reason why a surgery is required for these patients, is because that uncovertebral joint has narrowed. So we do have clinical practice guidelines related to the cervical spine, which is great. So these are coming from JOSPT, Journal of Orthopedic and Sports Physical Therapy. The revision was actually done in 2017. But the original cervical guidelines were written in 2008. We do have a translated version of the 2008 version and possibly the 2017. I'm not really sure. And you can find that here. You'll see at the top, the Chinese Journal of Sports Medicine has published all of these. And so what this guideline provides us with is the different types of patterns of neck pain that we will likely see in our clinics. And so we separate out neck pain into 4 patterns. This is the same from the original guideline and the revision. We have what's called neck pain with mobility deficit, and these are basically our patients who have a mobility problem, so decreased mobility of the lower cervical spine, so that's C3 to C7. We then have neck pain with headaches, which is really a mobility deficit of the upper cervical spine, so that would be C0 to C1 and C1 to C2. We have neck pain with movement coordination impairments, and what that means is that muscles, ligaments, the things that kind of control our neck are not working correctly. This tends to happen with trauma, things like a car accident, scooter accidents, things like that. And then our last pattern is neck pain with radiating pain. And what that means is that there's some issue with the nerve, usually at the nerve root, that is affecting the upper extremities. So they will report sharp shooting pain or some sort of numbness, tingling into their arms. And so when we think about these guidelines, I'm going to go into a little bit more detail related to them. But 2 of these 4 specifically, we relate to patients who possibly could need some sort of cervical surgery. And that's either neck pain with mobility deficit, but most likely it's neck pain with radiating pain. So if you listen to my presentation about the lumbar spine and things like a lumbar discectomy or a lumbar fusion, you'll remember that oftentimes the reason that surgeons do surgery is because the patient has a significant issue with the nerve root and nerves that are traveling down the leg and causing different types of dermatomal changes or myotomal weaknesses. And that's very similar to what we see with the cervical spine. So I'm not going to go into a lot of detail here. What the guideline provides us with is understanding of what the symptoms look like and the exam findings. And so that's here in Chinese. And you'll see that this is actually in a little bit different order. So we have the mobility deficit for the lower cervical spine, and then the movement coordination, the mobility deficit of the upper cervical spine or cervical spine pain with headaches. And then the last one is the radiating pain. So we're going to go into a lot more detail with this last pattern, the radiating pain pattern, because it isn't appropriate for you to be able to perform testing and diagnosis of radiating pain so that you can perform your own conservative treatment in the clinic. And there is that possibility that if it's bad enough, that those patients are likely going to require surgery. It's less likely for the other 3 patterns that surgery is going to be necessary. The guidelines also provide you with treatment options depending upon if the patient is acute, subacute, or chronic. And so again, these are treatment options for a conservative patient, so a patient who is non-operative, who is not likely to require surgery. So we will see those patients in our clinic very regularly. We especially see patients with mobility deficits. So when we're talking about this particular pattern, again, there's very little possibility, I would say, that you're going to see a patient after surgery simply because they have a mobility deficit. But I would say that these are patients that we see in our clinic pretty much every day. So if you're seeing a patient and they tell you that they're having pain, and they can say that it's usually on one side, or at least that one side is worse than the other side. And they'll show you usually in the interview that as they turn their head, they'll say, yeah, I have pain with that. Or if I try to extend my head, I have pain with that. So those are very common things to say. They could report some sort of awkward movement that caused them having trouble moving, or it's something that usually happens kind of over time. A lot of us are sitting at computers these days, like you are right now, and we're spending a lot of time in one position, and that unfortunately can lead to these problems. Sleeping in the wrong position also can lead to these problems. There are times when patients might report referred pain into the upper extremity, and that's referred pain from things like a facet joint that's not moving or soft tissue that's tight. So this is different than radiating pain. Remember, radiating pain is going to be numbness, tingling, that type of symptom. It's going to be a sharp pain, whereas this is more of a dull pain that can go into the upper extremity. So when we're examining these patients, this is, again, something you're going to see all the time, and you're going to get really comfortable with this exam. You're basically just performing range of motion assessment. And what you're going to find is that the pain occurs at these end ranges of range of motion, and oftentimes they're going to demonstrate decreased range of motion. As we talk about treatment for all of our patients with cervical problems, we're going to need to use as our assessment a palpation and looking at accessory mobility for the cervical and thoracic spine. So if you've taken Paul's class, then this should sound very familiar. We're performing assessments that look at mobility. And obviously, if the patient has a fusion, then we're going to recognize that that area doesn't move, and we're not going to spend a lot of time palpating for accessory joint mobility. But you are going to look at accessory joint mobility above and below where the patient has had a fusion, because we need to make sure that those are moving very well. Just a quick reminder of some muscles, some anatomy related to muscles. So we talked about the joints already, but we also need to remember that we have certain muscles that perform neck flexion. Those primary muscles are going to be the scalenes, but we also have what are called the deep neck flexors. And the deep neck flexors allow for capital flexion, which is the upper cervical spine and flexing through the upper cervical spine. And those tend to get very weak for patients who demonstrate a forward head. So this forward head posture is very common. I think we've all seen it. We all know about it. It's something that if they have a mobility deficit, we oftentimes are going to look for issues with posture and try to fix those. But this also can be a problem that can lead to radiating pain. And so we are going to also think about those deep neck flexors at some point following our surgery, if they do have some sort of fusion surgery. It's not going to happen right away, but we are going to look at those deep neck flexors specifically to make sure that they start turning on usually a month or so after the surgery. We also need to think about the neck extensors in terms of, like we talked about with mobility deficits, oftentimes they're going to have decreased extension. And with those patients with forward head, their upper cervical extensors, or what we call the cervical triangle, will oftentimes get very tight. So we're going to need to release that. And after cervical surgery, cervical fusions, those upper cervical muscles tend to get very, very tight. And so we tend to need to be able to get those relaxed because, again, most of our mobility after a cervical fusion is going to happen in the upper cervical spine and the upper back. And so we need to make sure that those muscles are moving well. Just to remind us of our rotators, we have things like the sternocleidomastoid, that cervical triangle, the muscles that actually that are actually going from C1 to C2 are very helpful for rotation at that level because, again, we're hoping that we can get rotation at that level. And then just to be complete, our side bending muscles for the neck, which again should work relatively well even following a fusion, are going to be things like our scalenes and our sternocleidomastoid. So those are all muscle groups that we need to think about as we are performing our rehab for these patients. Again, recognizing that their mobility will be limited, and so we need to make sure that they have good mobility at the levels where they are not fused. So let's talk about the primary pattern that you're going to see these patients demonstrating before surgery, and they may demonstrate some of these same symptoms after surgery. So we need to sort of recognize this pattern and be able to possibly diagnose these patients as well as recognize if this type of treatment is necessary following surgery. So neck pain with radiating pain means that something is happening at the nerve root, which you'll see here is kind of the yellow-green color. And those nerve roots then form trunks, and then they work their way through divisions, cords, and then branches of nerve that travels down the arm. And so this whole thing, it's really important that you understand that if there's a nerve root issue, it could affect any of those nerves that are traveling down the arm and then cause symptoms. And those symptoms tend to be radiating pain, so a narrow, sharp shooting pain that's going down the arm, and depending on which nerve is the most affected, it's going to demonstrate different areas of pain. The other big thing if that nerve root is affected is that they might demonstrate numbness, tingling, as well as weakness. And that weakness is what makes our doctors nervous and just helps them to decide if they should be doing surgery for this patient. So just kind of remind you of the nerves, the three nerves. So the median nerve, which comes down and goes kind of straight along the anterior portion of the arm, and then innervates and provides dermatomal innervation to the front of the first four fingers and basically the one half of that fourth finger. And then the ulnar nerve actually comes back behind the arm and goes through the ulnar groove at the elbow and provides dermatomal innervation for just the fifth finger and half of the fourth finger. And lastly, the radial nerve actually travels around the arm through the radial groove of the humerus and then down along the lateral side of the elbow and into the back of the thumb and first fingers and second finger. So that's where we're thinking if we hear the patient or have the patient show us where they feel their symptoms, it helps us decide which nerve might be involved, and it makes it a little bit easier for us to test that. And so your surgeons and you can actually perform 4 specific tests that really help you figure out if this is a problem with the nerve root of the cervical spine. And usually what those tests are is, the first one is what's called a Sperling's test. And you'll see a picture of that test here. And basically what it is that you're providing a little bit of cervical extension, side bending, and then rotation towards the same side, and then providing compression. And so basically what that does is that compresses the nerve root even more. And so a positive test would be the patient reporting that it's reproduced their familiar symptoms. So that numbness, tingling, sharp shooting pain down the arm. We also want to perform, so that's the first test basically, that if it's positive, okay, we're thinking maybe. So we need to keep going and test upper limb tension. And we're not going to go into detail with that here, but if we need to do that in lab, hopefully we'll have time to do that in lab. And if you're part of any of the USC programs, you know the upper limb tension testing. So we're testing for median nerve, radial nerve, ulnar nerve. And if one of those tests is positive, especially with changing head position, then Again, that's part of kind of allowing you to rule in the possibility of a radiating pain nerve root problem at the cervical spine. The other two things that we look at would be distraction. So cervical distraction allows for the nerve root to open up, and so it actually decreases symptoms. And so if you're performing a distraction test, which you can see here in the picture, and they report that their symptoms have decreased or stopped completely, then again, that's a positive sign that this could be related to radiating pain. And the last thing is that they report and that you can test for sensory strength or reflex deficits in the upper extremity that follow a nerve or nerve root. So they're going to show you weakness of certain myotomes. They're going to show you paresthesias of certain dermatomes, and they're going to have increased or decreased sensitivity of reflexes. So if you put all four of those together and they're all four positive, then it's very, very likely that they have a nerve root problem. And this is where a surgeon would say, okay, this is obviously pretty significant if it is, and therefore we would consider performing surgery after imaging. So again, we perform certain types of nerve glide testing and nerve glide treatment. This kind of shows you what we do for median nerve. We can go over this in lab if we have time. This one is a little bit more related to radial nerve, and this last one is related to ulnar nerve. So again, these are nerve assessment to see if the nerve specifically that's related to the nerve root is involved, and that's where their symptoms are coming from. This is just another set of guidelines that came out in 2018 from the PT Journal. The only reason I include this is because it gives you grades of research and shows you how significant different types of treatment and testing are. So this guideline, you'll see that there's grade A research, meaning the highest level research, to show that by performing a Sperling's test, the traction test, and the upper limb tension test, we can help rule in or rule out radiating pain. So the Sperling's test and the distraction test together help to rule in radiating pain. And if the upper limb tension test is negative, it helps to rule out radiating pain. So that just kind of gives you a little bit more information. There's some other things here, don't worry about them, but that just, again, sort of reiterates this idea that we can use those tests to figure out if the nerve root is involved. So I'm just going to finish up talking about considerations for surgery, and then we're going to talk about the surgery specifically in the next presentation. But what doctors are generally thinking about is issues related to myelopathy that's specifically related to the cervical spine. So that means some sort of inflammation, irritability, problems with the central cord. Something's going on with the spinal cord. And this usually presents itself with gait deviations. So they're not going to walk quite right, or they're going to tell you that they are walking and then somehow they just immediately lose their balance, things like that. Also, they would likely present with a positive Hoffman's test. So a Hoffman's test is where you actually you flick the middle finger, and by flicking the middle finger, it's a central cord issue, and it sends a signal that causes them to have to flex their thumb or index finger. So by having those things together, the inverted supinator sign is another one that you might see, and that is basically the reflex of the brachioradialis. And so if you do a reflex hammer at the brachioradialis, it causes the finger to flex, but the elbow doesn't flex. So again, this is another indication of some sort of central cord problem. Babinski test, hopefully you guys know that one. That's also central cord. And then this idea that somebody is over the age of 45. So as we get older, we're much more likely to have central cord problems. Other reasons that we might end up requiring surgery would be that radiating pain that we talked about with significant neurological and progressive neurological deficits. And that means that there's weaknesses, there's significant increases in numbness and tingling, those kinds of things. And then lastly, as with everything, if they're not responding to conservative treatment, but they definitely have nerve root compression, then they're going to consider surgery. So what we're most likely to see is this idea of degenerative disc disease or spondylosis leading to a cervical surgery. And so we talked about this a little bit. We talked about those uncovertebral joints that actually end up leading to bony hypertrophy, and that will then push on the nerve roots of the cervical spine. And so that's usually where we see these problems where they're going to choose to do surgery. And then we already talked about cervical myelopathy in the last slide, so that should sound somewhat familiar to you. But most of these people are going to report things like neck pain, upper back pain, headaches, radicular symptoms. So headaches, if you remember, was a separate pattern, cervical spine pattern. If they're just presenting with headaches or upper back pain, they are less likely, they're not going to be performing a cervical surgery for those patients, unless there's something else going on, like they don't have good blood flow to the head or something like that. But this type of surgery that we're talking about, the fusion, they're not likely to perform it if the patient's just presenting with headaches. But if they have that significant radicular problems, they do. It tends to be people who are not terribly old that get these surgeries. They tend to have very few other comorbidities. So it's just an issue where it's a neck problem for somebody, again, in their 40s and early 50s. So if the doctor is choosing not to do surgery and you're seeing them, which happens for the vast majority of these patients, you're really looking at this as usually it's the pattern of the neck pain with radiating pain. And so this can require different kinds of treatments like nerve glides. Traction, actually intermittent cervical traction, has been shown to be helpful for nerve root compression. And when I say traction, I don't mean traction sitting, which is what a lot of the traction units in China look like, where they're sitting in a chair and then they have something that pulls on their head. That actually is very ineffective. They need to be supine. They need to have a supine traction unit that allows for intermittent traction, meaning it turns on and it turns off. Joint mobilization, nerve mobilization, like I said, nerve glides, posture training, so really helping them to get out of that forward head posture, and then other exercises to improve soft tissue flexibility, so stretching, deep neck flexor strengthening, and overall conditioning. So that, again, we have totally separate classes that talk about treatment for these types of patients with this particular pattern. So we can do a little bit more in lab, but just recognize that this information is going to be seen more elsewhere. So I'm going to stop here, and we're going to start up next time with talking about when surgery is absolutely indicated and when it's not indicated, which we've kind of already mentioned in this particular presentation. And then we'll show the surgery and talk about rehab. So I'll see you next time.